So حكينا عن لبنان. We're sharing our story on how things happened. It was a very hard economic crisis. It is still happening. So, but at the same time, مثل ما قلنا إنه it has been a chance for people to consider change, for policymakers to look for reforms. They're much more open to ideas. نسأل panel إذا do you see the same بمصر? And if yes, what are the reforms يلي يعني سمعنا قبل شوي إنه the agenda of reforms is a very heavy one for مصر. So أولاً, do you see this openness for do you see this policy window خلينا نقول? And if yes, what are the reforms يلي هن على top الأجندة?
Assalamu alaikum. Thank you very much for inviting for the forum. And before answering your question, I'd like to thank you for your presentation. By the way, I like very much the slide of the key learning because really when we go through a crisis at the national level, rarely you can find someone is a very good observer and a team is working to start to build the learning curve, especially at the national level. So thank you very much. I hope that the whole system at your country start to work on this key learning, and by time start to see it on ground for the execution and the implementations. So back to your question, the answer definitely is yes. And before going to the how, I'd like to remember ourselves about the crisis and the definitions of crisis. And as we all know, there is a different types of crisis between the healthcare crisis and the economic crisis and maybe the political crisis. And for the healthcare crisis, the history tells us that since 1966 that we faced the smallpox, and moving to the anthrax in 2001 and the H1N1 in 2009. And I believe that the biggest one was the COVID in 2019 or 2020. And I believe that the healthcare system in Egypt has been very well prepared before the COVID, because the moving from the changing the structure from centralization to decentralization helped the agility of the healthcare system and the resilience of the healthcare system to cope with the crisis of the COVID, and actually which is the formation and development of different like the UPA, the ADA, the breakdown of the healthcare system between not only the MOH to be responsible for all the functionalities of the healthcare system, and now we have been getting a speech from the new national health insurance, moving to the UPA to the EDA. It helped a lot actually the decentralization. But actually, as I'm presenting the UPA, I can tell you about the new policies that has been implemented on ground in order to enhance the supply of the medications and the PPEs and the medical equipments. And the system inside the UPA has been changed and transformed to be very, very agile and flexible. For example, where we are moving this year or 2003 for the economic crisis, we have been changing the system of the pricing inside the UPA in order to help the suppliers to make the products available. On the old days, I believe it was very rigid, and it ended up to the shortage in the supply of the chronic medications, especially during maybe 2015, 2016. What happened is changing the purchasing process inside the UPA help us a lot in order to bring the best quality. I'm here spotting light on the medical equipments, and the unified purchasing for the medical equipments help a lot to decrease the cost by 33%, which at the end of the day has a very good impact on the PLL of the countries. Thank you.
Thank you. Thank you. And to to also take the perspective of Dr. Shireen, maybe the Jordanian perspective. So we were talking about health reforms in general, and we're talking about the agenda. How difficult do you see driving health reforms, and what are the major obstacles that can stand in the way?
Thank you for the invitation. At the crisis, mainly we have the COVID crisis. It shows the many gaps we had in our system. We exposed these challenges faced, exposed the need for efficiency, adaptability, and our ministry's business model resiliency. For structural reforms, it's a little bit difficult to structure innovation processes while existing procedures and regulation often restrain innovative initiatives. As you know, it's different preparing to introduce a specific innovation like specific treatment than to have structural innovative initiatives for the organization. For innovation in our organization, I think we have to adopt the ideas of products or services, administrative regularity, a system or plans, so to improve the health outcomes, efficiency, cost effectiveness, and to be patient-centered approach. For structural reforms in healthcare, we have to be included in the regularity and governance, resource allocation, and reorganization of healthcare provision. These are the areas we should concentrate on for the reform structure. And of course, with the collaboration of the partnerships and the stakeholders. I think for answering your question, we should look for working on the area of governance first, for the governance and regulations. If you would like to know our experience in Jordan, we are working by now on issuing, or we issued a regulation for telemedicine, which it eases the access of patients to the healthcare. One of the gaps of the pandemic is we've noticed that their access was difficult to the healthcare centers. So one of most important accomplishment is issuing this regulation, the telemedicine. Of course, we face the problem of automation. We started it, but its advancement is so slow. By now, we are working on it. We would like to leverage leverage digital health, and the most important to have data-driven solutions. We still have a problem of unified health information system. This is the main challenge for reforming, because if you have your data, you can analytics. It can identify trends, how predict disease outbreaks, how to optimize resource allocation. Another obstacle is the human resource. They need to be less resistant to change for innovation. They should be trained well. They should have the commitment or to be involved in these strategies. And the last is we have to adopt healthcare provision models for patients. healthcare models we are adopting by now. As you know, we have the burden of NCDs by now, and we have statistics of having over 80% of death in Jordan because of the NCDs. So the structural reform is to have care provision models. One of those we adopt for now is the family health team-based model. It has many advantages. One of them is to lower the burden of hospitals. We are increasing the healthcare centers. We are doing telemedicine. We are medicine delivery to homes. So we have the structural reforms on these aspects: regularity, governance, and resource allocation, and on healthcare provision. Thank you.
Thank you, Dr. Shireen. So I guess reforms can be big moves or could be even sometimes continuous and at a smaller scale. So I will turn now to Dr. May. And talking about big plans, universal health coverage in Egypt is a big plan. And although the plan is there, we, especially in the previous years, every country has been facing a lot of unexpected events, a lot of change in plans. So how do you see, how do you handle this? How do you see this in Egypt? There is this plan to expand universal health coverage, but at the same time, the war happened in Ukraine, countries were affected. How are you handling this, and how does this affect the plan?
Okay. صباح الخير على حضراتكم. Well, let's say in الريفورم اللي حصل في مصر الهيلث انشورنس أو الuniversal health insurance, this kind of transformation الحقيقة it was in time to help to face the crisis that happened all around the world. لأن لما نيجي نبص على السيستم الحالي أو اللي كان موجود قبل كده كان في يعني we were suffering from fragmentation of the system. We were suffering from that there's rare of resources of financial resources. ما فيش sustainability. في mix ما بين تقديم الخدمة وما بين الفاينانس بتاع الخدمة. ما فيش monitoring واضح. ما فيش quality control واضح على services provided across the country. ما فيش social protection لل vulnerable groups. دي كانت مشاكل tackled before going to the reform. So when we went to the reform in 2018, that was the establishment of the launching of the law, and we started the implementation now in 4 governed rates. كنا حريصين جدا ان نراعي ده، وده اللي ساعدنا في الكرايسيس when it happened and it hits the world. لان كان في separation of functions between the service provision and the purchase of the service itself and the finance of the service. When we talk about the finance part, we were very keen to make sure that there is sustainable resources not attached to the treasury per se. ما يبقاش كلها جاية من خلال تمويل من الخزانة العامة للدولة. It was more of earmarked taxes and some investments and from the contributions itself. فده ساعدنا. كان في جزء متعلق بال vulnerable groups and there is a subsidy for their contributions coming from the state. وده ساعد جدا في الكرايسيس when it hits ان ما كانش فيه عبء مالي على الغير قادرين ان هم يتحملوا تكاليف العلاج. كان عندنا الفكر بتاع ان يبقى في promotion للpreventive والprimary health care ويكون في accessibility ليهم، وده ساعد جدا برضو في الفترة الأولانية. لأن دايما كان قبل كده الثقافة انك ممكن تخش على secondary والtertiary. لما بتعمل accessibility حاليا للناس ان هي تبقى في preventive وفي primary، ده بيساعد قوي ان يعمل cost contamination من ناحية، ومن ناحية تانية بيقلل من ال consequences الصحية اللي ممكن تحصل في المستقبل. فده كمان كان مساعدنا. كان في competitive pricing، ده ما كانش حاجه موجوده قبل كده، فساعدت ان يبقى في players كتيره يقدروا ان هم يخشوا في السيستم، ما يبقاش العبء كله موجود على الدوله بس، ممكن كمان البرايفت سيكتور يحصل engagement ويبقى معانا بيقدم الخدمه، فبقى في accessibility للخدمه من الجميع، بقى مش limited لعدد محدد من مقدمي الخدمه. ده ساعد جدا في المرحله اللي كان فيها الازمه، ان نقدر ان احنا نتلقى الخدمه لو ما هياش متوفره في القطاع الحكومي، نقدر نشتريها من القطاع الخاص، القانون بيسمح بده، فادانا مرونه ان احنا في وقت الازمه نقدر ان احنا نوفر الخدمه بشكل افضل يعني. شكرا.
Thank you. Definitely the experience تبع مصر ب universal health coverage is a very large experience, and I hope there is some research documenting the process and papers. It will be also good, I think, to share the experience مع غير بلدان مثل لبنان. عم نحاول هلا نعمل هالقانون. Thank you again. Dr. Ahmed, from your position, دايما whenever there are big plans بالهيلث كير في انتقادات دايما انه you need to also think shorter. عم بحكي بالاجمال، مش دايما في هالدايلما انه we need to address the short term needs at the same time في proactive long term plans. How do you look at this? How do you manage this?
First of all, thank you so much for Arab Health Economic Society for inviting me today to be with you, and thank you so much, Dr. Wadia, for moderating this session. And I'm very happy and I'm very glad and very honored to be here with our eminent panelists here. So thank you so much. First of all, I want to thank you for your speech about Lebanon experience and how you are now moving forward to do more legalization and national strategy for Lebanon. I will read about it because it's very interesting for me. So thank you so much. And of course, I want to thank Dr. Hisham for his insights about our experience in pandemic era and how Egypt was very steady for this pandemic era because of the health reform which is started already in 2014 by His Excellency, our President, vision for all health reform. Our hospitals were very ready for this pandemic. Thanks God for all steps and procedures that the government took at this time. And of course, I'm very honored today to know that we have now 30% decreasing in our cost for purchasing supplies and medications by UBA policies and procedures that already happened, and we are going further. And of course, I wanted also to thank Dr. Shireen for her insights about Jordan experience and how you are already doing governance and how you are doing well for health sector reform also. And of course, I want to thank Dr. May Farid and her experience. Dr. May Farid, one of the eminent of universal health insurance here in Egypt, and I think in the region. So thank you so much, Dr. May, about your insights about the governance. I want to back to your questions about long-term and middle or in short-term plans for any country after relating to health crisis management. So there is a difference between crisis management and the health security, because in the health we are using, most probably we are using health security for national disaster and all things related to public health. So for short plans and for longer plans, for short plans we are dealing with how we are dealing with the resources and the assessment of our current situations and how we are thinking about our resources now and mobilization for these resources for rapid response for short plans and how to mitigate with these incidents that happen. Thank God in Egypt we have no national disasters like other countries, like volcanoes, like earthquakes, but for all countries facing pandemic. But thank God till now in Egypt we are not facing national disasters that we are need for short plans. So we are usually working in Egypt on our long plans So our long plans, as Dr. Hisham said, about policies and procedures that we are setting periodically for continuing proactive procedures and proactive actions for any crisis or any health security incidents that will happen in the future, inshallah, not happen any. So also to divide for these plans, we have to talk for around 5 pillars for these plans. So if you are talking about resource mobilization and policy reforming, and also the private sector engagement, which we were calling about triple B. So now it's private sector engagement, and how the role is very important with the government, as Dr. May mentioned about our new health reform and the governance models that let all facilities are compete, whatever it's private or public, and in the health provision, and also in private sector engagement in our experience in Egypt Health Security Authority. So we are working well in this private sector engagement in many levels, relating to health provision or relating to medical supplies and medication for sure with companies, and also with international organizations. And also we are talking about community engagement, which we have a good experience here in Egypt, as we are, if you are talking about aging ratio for Egyptian people, here we are almost 60%, according to World Bank statistics. About 60% of people are, thank God, it's our youth. They are youth. So the community engagement is very important for all people to be engaged, as our experience in hepatitis C during our scanning and screening and vaccination of hepatitis C, when it's involvement of all community, it's becoming almost, thank God, eradication of virus C, and the recognition from WHO about Egypt experience for eradication of this virus C disease. After we were one of Egypt was very high ratio in this disease. So after all these 4 pillars, we have to make a continuous a continuous assessment and a continuous evaluation for all our procedures and for all our policies. And for sure, we cannot forget the role of all international organizations like WHO and World Bank and the EU for supporting the government and supporting the community for this. So thank you so much again, and I hope that I'm not taking a long time. So thank you so much.
Thank you, Dr. Ahmad. Talking about intergovernmental organizations, we will now turn to Dr. Awad Mataria on the screen.